Roux-en-Y Gastric Bypass. I've got no disclosures. So when I first started bariatric surgery, as Jim said, I thought gastric bypass was the cure for reflux. If someone had a problem with reflux, you did a bypass. If they'd already had obesity surgery, well, you converted it to a bypass. Many of the causes of reflux are exacerbated by obesity, and a number can be affected by Roux-en-Y Gastric Bypass. Studies have shown improved symptoms, reduced PPI use, quality of life improvement, and reduction of esophagitis post-bypass, as well as reduction of reflux on barium and improvement in pH impedance. And a meta-analysis by Sargison suggests an improvement in Demeester score of about 16.5, with almost 80% discontinuing PPI therapy. Nevertheless, in a large recent population-based trial, Holmberg suggested that the effectiveness of bypass on reflux may be overstated. In their study, 2,500 patients with preoperative reflux, it recurred in about half the participants within 2 years, and that remained over the next 10 years. They also pointed out that not many studies have actually demonstrated long-term effect of bypass on resolving reflux symptoms, and of those that did, the sample sizes were small. The mechanism of reflux after bypass is often attributed to either excess gastric pouch left behind, permitting continued production of acid by parietal cells, or due to surgical creation of a short alimentary limb, resulting in bile reflux. There may be an obvious problem like a gastrojejunal stenosis, amenable to dilation, or gastric fistula, and as many as 1.6% of cases in Higa's series had that, and that can lead to acid returning to the esophagus. Diagnostic certainty is difficult, and it can require functional and anatomical tests, including endoscopy, barium radiology, pH monitoring, impedance testing, esophageal manometry, and even perhaps gastric emptying tests. We know that GERD, health-related quality of life, improves following sleeve with meticulous hiatal assessment and repair of hiatal laxity and herniation. And does the same happen with bypass? Well, Borbely carried out an evaluation of radiologic, endoscopic, and functional patterns in patients with symptomatic reflux following gastric bypass, and a high percentage of hiatal hernias, together with hypertensive lower esophageal sphincter and motility disorders, were pivotal findings. Vaughan conducted a retrospective review of patients with gastric bypass who underwent subsequent isolated hiatal hernia repair at an average of 5 years. And the most common presenting complaints were dysphagia, reflux, and pain. Patients undergoing revisional bariatric surgery as well as hiatal repair were excluded from this. Non-absorbable suture was used, and a third had a bioabsorbable mesh repair. Surgical repair yielded high rate of symptom resolution in the short term, with 70% reporting complete resolution at 28 days and 23% reporting partial resolution. There were two radiologic recurrences and one required reoperation. It'd be nice to see a long-term review of this. There have been several published case reports and videos on Nissen fundoplication following a Roux-en-Y gastric bypass, and Kawahara described a patient with intractable reflux and a Demeester score of 67.8, with endoscopically proven esophagitis, free-flowing reflux on barium study, but proper emptying of the gastric pouch. And they did a standard 360-degree short floppy Nissen wrap using the excluded stomach around the lower esophagus. And the patient showed marked improvement and healing of the esophagus with a reduction in Demeester score, and they were asymptomatic at 6 months. Using that technique, Colpert published a series of 6 patients undergoing this modified Nissen fundoplication for therapy-resistant reflux within a 12-month period, and that surgery took place between 3 and 11 years after the bypass. At the time of fundoplication, they had a mean BMI of 31, and all patients were dependent on PPI. 4 out of 6 had a herniation of the gastric pouch through the crura, and within a month of surgery, 4 out of 6 were off PPI, and 3 out of 6 remained off PPI at 6 to 12 months. Everyone has their favourite technique for fundoplication, and Giro's described a simplified heel repair, and there have been toupe and door repairs described as well. But I'm unaware of any literature comparing the different types of fundoplication. We've just heard about links. Magnetic sphincter augmentation is a relative new technique. Broderick carried out a retrospective review of their prospectively collected database, looking at patients who'd had previous obesity surgery, including sleeve, bypass and switch, and their findings demonstrated that augmentation is a good alternative for refractory reflux with reduction in PPI usage and health-related quality of life. And that technique's evolved now to a full hiatal dissection. It's no longer limited to hernias of only 3 centimetres in size, and patients can eat and drink immediately post-op, and beads are MRI conditional now to 1.5 Tesla. There's a small rate of erosion, but that's thought to be about 0.3% after 4 years. Radiofrequency therapy has been proven to be successful. Stretta's the only one that's NICE approved in the UK for cases refractory to medical therapy. And in a series of 11 patients having had previous gastric surgery, including bypass, 9 out of 11 patients demonstrated improved GERD health-related quality of life scores at a median follow-up of almost 2 years. In patients with no history of previous gastric surgery, Stretch has shown a reduction in the dependence on PPI, but in most patients it can't be completely discontinued. So considering PPI usage as a measure of success, 73% of patients in this series could continue or reduce PPI, discontinue or reduce PPI, which is similar to studies evaluating Stretta in the non-gastric surgery group. So bile reflux, Schwartz described this a long time ago, 2008, and they reported on a series of patients with chronic pain after gastric bypass, owing to an abnormally short biliary limb. It's a complication caused by technical error while performing the anastomosis. To differentiate between bile reflux and regular gastroesophageal reflux, pH meter tests should be conducted since the manifestations are the same. And bile reflux is due to a short limb, in this series often less than 60 centimetres, and we would normally expect a 100 plus centimetre limb in gastric bypass. Obviously further surgery is indicated to lengthen the limb. And there's also another case I've not come across myself, but there's a more unusual reflux-related problem. Lavella described bile reflux into the remnant stomach, causing chronic abdominal pain, together with a series of symptomatic patients undergoing remnant gastrectomy. At a mean of 4.4 years, 19 patients underwent remnant gastrectomy for bile reflux gastritis. They were all female, all presented with pain, mainly epigastric. Most underwent remnant endoscopy, often using a push or laparoscopically assisted technique, and a HIDA scan demonstrated bile reflux across the pylorus. So the surgical approach was laparoscopic or robotic in all but one, and a hospital stay of about 2.7 days with no major complications. So in conclusion, reflux can present after gastric bypass. It may well be related to technical errors. Hiatal hernia, narrow calibrated gastrojejunectomy, long gastric pouch are all factors associated with the development of pathological reflux. Techniques are available to treat the condition, like hiatal repair, fundoplication, sphincter augmentation and links. But despite the growing number of reports of reflux after bypass, it should still be considered the best surgical option for patients with obesity and a large hiatal hernia or complications secondary to reflux disease. Thank you very much.
Thank you, David, for showing us that no procedure is infallible.